extraction, and there is a faster recovery and healing, does not cut or remove corneal tissue, cornea retains its natural shape, there is less glare issues on patients with large pupils, and very stable over time, no regression, and above all, I think the best part is that it is a reversible procedure. But there are some downside, but they are limited too. There is surgically induced astigmatism, which is very, very minimal. Corneal endothelial cell loss, which is also very minimal. Iris ovalization, more common with the iris claw lenses. Chronic uveitis, not associated with the ICL, which we are going to focus here on during this course mainly. Glaucoma, there is an issue, but not very high percentage of cases they land up with glaucoma, or there is a complication in the procedure or white to white measurement is inaccurate, then person can have. Pigment dispersion syndrome, more common with the iris claw lenses and angle supported lenses, formation of cataract and endophthalmitis. So variety of phakic IOLs have been tried. They could be angle supported, iris fixated, or posterior chamber PIOLs, phakic IOLs. So the quest for this has started very early, right from 1953. We are seeing various models, as you can see here, and they are given in the literature. But recently, in last 2 decades only, we have come out with the successful options and better, more viable, more suitable options. So there are various lenses available in the UK, not in the European countries and not in our country. And current designs which are there available in our country as well as iris fixated vari-size phakic IOL. It's FDA approved PMMA, made up of PMMA material, highly predictable and relatively safe. Large incision causes astigmatism because it requires 5.5 or 6 millimeter incision. Endothelial cell loss is there because it is an iris fixed lens. And the glare issue is there because if we correct a higher power, then the size of lens decreases and chances of disenclavation, as you can see in our case. And we started doing phakic IOL way back in 1994 or 95 when they were available. Veriflex is a foldable version of this very size. Now these two also have lost their glory to their to work in our country, and I think ICL has clearly taken up the other available lenses which were there in the market. And then Acrisoft, Elcon company has launched Cachet phakic IOL, and this is the foldable version, not FDA approved, but CE marked, single piece acrylic material, foldable, no iridotomy required, fast visual rehabilitation. But these are all, I tell you, not very popular. Only this ICL, which is the most popular, and I think for this only all of you have come over to know more about it. It's made up of polymer material which absorbs ultraviolet radiation. There is a central vault, as you can see here, and it's a made up of foldable material, but there is an issue of sizing if it is inappropriate. ICL is FDA approved, vari-size is again FDA approved, Acrisoft Cachet is CE marked, as I said. And I will like to mention something about the IPCL also, I don't know, which is now available from IOCare company in our country, and in the year 2014 it was launched. It is made up of hydrophilic hybrid acrylic material. The lens is customized according to shape and size of each eye, and widest power range right from plus 15 to minus 30 diopters, with still up to 8 diopters. I have corrected up to 22 diopters with this, but again this is not FDA approved, and overall size from 11.5 to 14 millimeter in 0.25 millimeter steps. So this, and there are 6 openings in it for the equalization of the aqueous in the anterior and posterior chamber, and this is a vault, as you can see here, and the shoulders, 3 shoulders on each side rest the lens in the ciliary sulcus. So coming to the workup, the advantages of ICL is that it's made up of collagen which attracts fibronectin. This fibronectin makes a single layered surface which is a protein here, and it repels other proteins to deposit on it. So this way There is better optical performance because there is no deposition of protein on the surface and less glare and halo issues. And it is a very flexible material. And as you can see, the transparency and clarity is as good even after 5 years. I am doing it for last 9 years now. And the lenses and the patients are very, very satisfied with this. And they are available from minus 0.5 to minus 18 diopters and from plus 0.5 to plus 6 diopters. Astigmatism can also be corrected with this. A complete ophthalmological assessment has to be done. This is very, very important. And we have to know about uncorrected visual acuity and best corrected visual acuity. Refraction has to be done, both manifest and cycloplegic. Slit lamp examination, assessment of cornea and lens, whether there is any opacity or any other problem in the cornea, which can lead to change in the power of the eye. And endothelial cell count should be more than 2,200. Intraocular pressure should be within normal range. There should not be any glaucoma of any type. Fundus examination should be done thoroughly. And anterior chamber depth measurement. This is again a very, very important step, and it should be less than, more than 2.85 millimeter from endothelium. Corneal topography and keratometry has to be done, and corneal horizontal white to white distance. So these three things are there, which is different and which has to be emphasized and which has to be taken care of very seriously. We should not do it lightly. So ICL and sizing. So I will emphasize this very much. Accurate pre-operative white to white and anterior chamber depth measurement is very important. ICL provides a vault. As you can see, a vault is the distance between the clear anterior lens surface and the posterior surface of ICL, as I am showing here. So this is the distance between the lens and the ICL. And it should be from 0.25 to 0.75 millimeter. So how to know about it? It should be, you can check it with the thickness of the cornea. This is the corneal thickness and this is the central distance. And it should be of 0.5 or 1.5 time, half to 1.5 time of the corneal thickness. So this has to be kept in mind. So you can easily check it and compare it with the cornea, whether it is less or more. So if in the undersized ICL, if the vault is less than 0.125 millimeter, then there is an increased risk of anterior subcapsular cataract because of the contact and resting of the ICL over the lens. If the ICL is oversized, that is the vault is more than 1.5 times, this will push the iris forward and close the angles, which could lead to intraocular pressure rise and glaucoma. So this is very, very important. This is the A scan, where we can see two spikes of the ICL and the lens. So white to white measurement can be done very easily with the digital caliper, and it is available with the company. And here you can do it very simply, or with the same caliper, simple caliper also you can do. This is a digital caliper, and here you can see it is 11.16 millimeter, right from white of either side, and you have to take care of the arcus if it is there on either side, and that has to be avoided. And white to white measurements by Pentacam or IOLmaster or OrbScan are not very accurate. People are using it, but I and the company and I personally would not recommend to use such measurements, and it is better to use the measured by the digital caliper. This lens has got a centraflow which has got an opening. It is from ICL V4 family. It is stored in BSS. It comes in a normal size. Earlier it was not, it was stored in a saline, so that was the underside lens. A central port of 360 micron in diameter is designed to restore more natural aqueous flow and eliminates the need for iodotomies. As you can see here, this is an opening of 360 micron in the center, and there are 3 openings here. So they are meant for, the other 2 are meant for redundancy. For the, due to any reason, the central one is occluded, the other 2 will provide the redundancy for the central optic part. Iridotomy with the newer generation ICL is not required, but it can be done in two ways if you feel so. By YAG laser, which can be done 1 to 2 weeks prior to this patient taken for the surgery, and there is a less amount of pigment dispersion, as you can see here, or it can be done intraoperatively, surgically. For the toric ICL, we need to mark the horizontal axis at the slit lamp as you do it with the toric IOL case. The patient is seated on the slit lamp, and you can make 3 marks as you can see here, or 2 marks as it is, as you feel like. So, and this can be, the same patient can be taken to the OR. This is how you can do with the bubble marker, which all of us now we have with the toric IOL if you have an experience of doing it. So this is the 2 simple way of marking pre-operatively. Then this sheet comes along with the lens, and come to know our incision has to be at 180 or 0 degree, and then you have to rotate the lens clockwise or counterclockwise, as is mentioned over here. Rotate lens clockwise by 17 degree, and this how you can place it, or you can measure it by this caliper on the during the operation table. Now we are doing it with the Varion. Preoperatively, the pupil should be well dilated, 8 millimeter, to avoid distortion of ICL. It has to be done under topical anesthesia. Draping and speculum, as we do it with the normal cataract or other cases, all done in a sterile technique, in a sterile OT. Loading of ICL is important, and it should be done before the patient's eye is open, and lens is taken with the soft tip plunger from the vial, and it is brought out, as you can see here, and with the vault anteriorly, and with the opening there on the right side. There is a hole which has to be placed on the right side, and vault has to be placed anteriorly, and then with the front loading technique, the coin-shaped forceps enters inside and holds the lens, and gradually the cartridge is slipped over the forceps. You don't have to pull the lens, rather you have to push, make the cartridge travel to the other side. So because it's a very thin lens, so chances of damage during loading can occur. Advancement of plunger to push the ICL into view in the cartridge barrel has to be done after this. So a clear corneal 3.2 millimeter tunnel has to be created, as you can see here. This is a 3.2 millimeter blade. This is recommended. Maybe we can do it with 3 millimeter also, but this goes easily with this without damaging. And do not overfill the anterior chamber. There are 2 paracenteses because I use bimanual irrigation aspiration. Then the lens is gently, 75% of slowly, lens ICL is pushed inside slowly, and let the part open, and then rest of the lens is pushed inside into the anterior chamber over the surface of the iris. And then with the help of this instrument, you tuck the haptics behind the iris. And this is irrigation aspiration. This is an opening here, and we use viscoelastic, but I am now using the Orogel for this because it comes out in a bolus. And after removal of OVD, hydration of the incision is done, and after the procedure is over, we give the patient 2 tablets of acetazolamide. This is very important to decrease the rise in intraocular pressure in the immediate post-operative period. We have to keep it in mind that we should not rotate the lens, the ICL over the lens capsule, because this can damage the zonules. And do not push the ICL with the IA tip, and because this can damage the thin central optic part of the ICL. Do not lift or massage the iris to resolve iris capture. Place the foot plates and haptic gently under the iris, as you have seen in the video. 2 hours post-operatively, we should check for the intraocular pressure. If it is more than 24 millimeter mercury or more than 10 millimeter rise from the pre-operative IUP, then we should think that there is a retained viscoelastic, which is one of the commonest cause. So we have to take this patient in the OT again and remove all the viscoelastic and check the patient again. Non-patent iodotomies, nowadays we don't make iodotomies, but if you are making, then this could be one cause. Shallow anterior chamber, high vault due to oversized ICL. Anterior chamber depth should look deep or normal. And check pupil and ICL centration. Check ICL vault. Low vault is common at 2 and 24 hours. Antibiotic and steroid eye drops are instilled as we do it in another our routine cataract cases. Oral NSAID is prescribed for a day or two. Follow up like a normal cataract routine. Antibiotic and steroids are used for 1 month. Antibiotics for a week or 10 days. So post-operative pentacam picture, as you can see here. And this is a post ICL. This is central flow. You can see the opening here. And everybody will think that this is cataract, but this is not. This is retained viscoelastic behind the ICL. These photographs were sent to me by someone for opinion. So I am just showing it with his consent, due consent. So we have to remove all the viscoelastic from behind the ICL. Otherwise, you get confused that this is. So one video I will show. It's less than a minute. Now what we are doing for toric ICL, we are now this is the patient, the chart and table which we get. Incision is made at 180 or 0, as you can see, and 2 side ports are made, paracentesis, and the lens is pushed gently inside, and this comes with a mark, as you can see here, and this is aligned with the mark on Varion. It's perfectly aligned. So we don't have to mark preoperatively or intraoperatively. There is no smudging of the surface of the eye, and it is well placed. And this is aligned with the mark which is there present on the toric ICL. To tell, my first ICL was toric ICL. So this is how I started. So toric ICL is also not very difficult. ICL exchange is also easy. This case rotated. When it was implanted, this was a toric ICL. We found that it has rotated by 180 degree. So I will show my experience of explanting it. What we do is we push some viscoelastic in the anterior chamber and behind the lens. This is behind the lens. Lift it and pull out one of the haptic over the surface. And with the same coin-shaped forceps, you hold it because it provides a very good grip. And you hold it and pull it out through the incision without any assistance. It comes out very easily because it's a foldable thing. So ICL is safe, reversible, good and safe option, very stable over time with no regression. Thank you. Thank you well.